This week on the BackTable podcast.
Voiding diaries are great. The problem with voiding diaries is they're a pain in the butt to do. I think I'm assessing the patient to say, hey, is the data I get from the voiding diary going to help me? Like any test we order, whether it's a urodynamic, a uroflow, or a voiding diary, it's not going to really drive or change things. I'm maybe a little less inclined. The case she gave us with Nocturia, is this really Nocturia? He's going to the bathroom 4 times a night and that's it in isolation. Voiding diary, hugely beneficial to rule out something like nocturnal polyuria. Or are we talking about 4 times a night because that's what he remembers, but he's peeing 15 times a day, which is excessive. And this is maybe a little bit more indicative of an overactive bladder or possibly an overactive bladder with an obstruction.
Hi, everyone. Welcome to our conversation about male urinary tract symptoms. I'm Chris Tengerjaya, along with Benjamin Brucker and also Craig Comiter. Today, we're going to be talking about blame the bladder or bust the prostate. So I'll be your host today, guiding us through our discussion. It should be a wonderful about 45 minutes in regards with our experts. And so I would like to welcome first Benjamin Brucker, who's a professor of urology and OB-GYN at NYU Grossman School of Medicine, is also the director of urogynecology and reconstructive pelvic surgery at NYU as well, as long as we have Dr. Craig Comiter, who's a professor of urology and OB-GYN at Stanford University and is the director of urogynecology and reconstructive pelvic surgery at Stanford. So welcome to you both. Happy Valentine's Day to you. Thank you for spending it with us here today.
Great. Thanks, Chris. And Craig, great to see you. Real happy to be invited and excited for our discussion.
Same here. Best Valentine's Day I've ever had.
I don't know about that, Craig, but we'll get right into it. So I find it interesting that we have all 3 of us members of the Society for Urodynamics and Female Pelvic Medicine and Urogynecologic Surgery here with us today to lead this discussion about male urinary tract symptoms. And I just kind of want to ask both of you what your thoughts as members of SUFU, but also people who treat male LUTS. Maybe that gives a distinct perspective in regards to voiding dysfunction.
Thanks, Chris. Good question. And I often have patients sort of wonder when there's a urogynecology on my card along with urology, why I'm talking to them about prostate health or BPH. I think in a lot of the concept here is, and it's great that SUFU is a part of this, urodynamics is a study that examines and explores the bladder. And that's primarily what the test is looking for. And I think a long time ago, we realized that bladders are really the same, whether we're men or women, and there may be different pathophysiologies that exist, as we age or with different disease processes. But I think the perspective that we have is we're really thinking about the bladder and thinking about the prostate in relation to the bladder, as opposed to just thinking about the prostate as sort of a more innate organ. So I think that gives us a perspective. One of the things that attracted me, I guess, to the field in general and SUFU and fellowship in sort of the urogynecology space that has some of the BPH is just that. And I love the variety in being able to treat men with bladder dysfunction, maybe secondary to the prostate, and also women that have bladder dysfunction. But today we'll put on our BPH hats and talk a little bit about male voiding dysfunction and BPH.
I think very similarly, I remember back when it was called the Urodynamics Society. So it originally was a society to distinguish neurogenic versus non-neurogenic voiding dysfunction. And then it suddenly morphed into the SUFU. So I agree with Ben that we've got bladders, we've got outlets, and there's a pathophysiology that we treat.
So it's also interesting in regards to talking about the development or evolution of our society of urodynamics and where we've gone. And so Ben talks about having urogynecology on his business card. I mean, how is it that both of you came involved in regards to just treating male LUTS? Is that really much of your practice anymore, or do you still do that a lot?
Yeah, so I would say that probably the male voiding dysfunction is about 40% of my practice, so it's a big part of it. I do see a lot of neurourology as well, and just because someone has Parkinson's or MS doesn't mean that they don't also have VPH and an enlarged prostate. So in some ways, I think I'm seeing all of it. And there are just straightforward guys that a primary care will send in that have an enlarged prostate or might even have, some urinary symptoms. So in terms of my practice, it's a big part of it. Again, we sort of in fellowship probably emphasize it a little less because a lot of the BPH training happens in residency, and a lot of the fellows want to get a little more exposure to the female side of things and the prolapse and some of the neurourology. But we try to tailor it to what the fellow ultimately hopes to gain, in the future and what their practice they hope, looks like. Try to help them get to that goal.
And we have a very varied faculty at Stanford. So I have partners who see almost exclusively female patients, and I just follow the population. I see 50% men, 50% women. So it all depends on who you're referred to. But Ben's right. That stamp of urogynecology can be confusing, but we're trained in evaluating bladders, evaluating outlets, and if surgery is needed, doesn't matter the gender.
We'll talk a little bit about it, but we talked about urodynamics a couple of times. I just don't want people to think that every patient with BPH has to have a urodynamic. We're just, I think, trying to give a little bit of the understanding as to why we may think about things a little differently and came from generations where people did more urodynamics. And so the way we conceptualize some of the obstructive processes, I think, but we'll get into that, I'm sure, Chris.
So thank you both for those comments in regards to that and how you've come to male LUTS and what you've done in terms of your careers with urogynecology and also SUFU. So as we start, I like to always start off with a case. I think that's the best way to represent things. And we always start off with this index patient. And for, are we busting the bladder or blaming the prostate? I'll give you guys a case and we'll riff on it. So if you have someone who comes to your clinic who's, let's say, 67 and his main complaint is frequency and nocturia, and don't worry, it's not going to be a board style question where you're going to fail immediately and fly home from Dallas, but we don't do it in Dallas anymore. I'll give you some parameters if you want them or not, or if you just say, hey, this is 67-year-old Joe in your clinic with frequency and nocturia, how you handle that. So Craig, what's your thoughts in regards to frequency and nocturia in a male?
Well, that's usually all that we get is the patient comes in with 1 or 2 sentences of complaint. So we elicit more from the patient. We like numbers. How frequently do you void? How many times do you get up at night? How is your stream? Do you feel like you're empty? Is there urgency? We basically ask all the IPSS questions and more. So we would get that information. And personally, I like tests that have no risk and give free information, such as uroflow and post-void residual. Most of the patients get that before I even see them. It's something that's done by the medical assistant.
Ben, is that similar to kind of your workflow in regards to getting a uroflow and PVR on everyone?
Craig mentioned before, we have bladders and we have outlets and we can have problems with both. So when I'm asking my questions, I'm trying to figure out, is it a bladder issue? Is it an outlet issue? We break it into the storage and the voiding symptoms. So I think questioning and sort of digging into some of those IPSS type questions and actually giving the questionnaire can help illustrate a lot, not just the composite score, but actually looking at what's driving that score. And Craig had sort of alluded to, uroflow and PVR, and I think those are great tests and would help me decide a lot in a non-invasive way.
So for all those listening out there who may not be familiar with uroflow and post-void residual, Ben or Craig, I mean, what are numbers that stand out to you or patterns that would be concerning in regards to this patient who comes to you, whether you are blaming the bladder or busting the prostate?
Yeah, so I mean, one of the first things we look at in a uroflow is trying to understand the voided volume. And I think that for many of us that treat men with overactive bladder and not necessarily men with only BPH, we try to get uroflows and a guy will come in and say, oh, I really needed to go to the bathroom and I only peed 70 ml. Obviously, that's a little bit maybe suggestive that he's got more of a storage issue or a bladder problem where he can't hold a lot. But in general, we're looking for a voided volume of greater than 150. And we're looking at the maximum flow rate and the average flow rate and trying to get a gestalt from that. Generally, if we're in the 20, 25, 30 range, those are things where I'd say I'm not really that worried that there's an obstructive process, although you still can have obstruction with higher flow rates. And if we're in the 8s, 9s, 10s, those are more suggestive of maybe there is something that's obstructive. We're a little limited. We can't necessarily define it only by uroflow, and that's where in some cases a urodynamic may have a role. But then we also with the uroflow want to know the pattern. So the pattern can suggest if it's really a plateau, something like a urethral stricture. If we see a prolonged sort of bell-shaped curve or sort of a little bit of a bell shape, maybe more suggestive of a BPH. Sometimes there's an undulation or a pushing where someone's straining. And then I think the post-void residual is also very telling. Post-void residuals being quite elevated do suggest that there's a maybe more chronic obstructive process ongoing versus a low PVR. And again, a small voided volume, but a real desire to void might suggest, hey, maybe this guy's a little bit more of an overactive bladder.
I agree completely. I sometimes look at uroflow as a screen for obstruction. If there's a normal flow, obstruction is unlikely. Possible, unlikely. And if there's a low flow, we used to learn, and we still do learn, that could be obstruction or a weak bladder. But as Ben alluded to, there are certain patterns that can be diagnostic. A box-shaped or a long plateau, that's often a stricture. If the low flow is early peak, then it's obstruction. If the peak is in the middle of the uroflow, then it's more likely a weak bladder. So we can get so many clues from this uroflow, and again, a test with no risk.
And you're also looking at the patient and trying to assess the patient. Usually by this time, we've done a physical exam. We know if the guy has a large prostate, for example, on a rectal exam. We've sort of looked to see if his meatus is patent. So there are some basic things that we should be doing. We're also hearing the history, right? You gave us sort of a little snippet, but one of the fun things of, I think, the functional urology side of things is really trying to understand that natural history. This isn't like a CAT scan found something and now we have to treat it. We're hearing and maybe talking to him and he says, yeah, I saw a urologist about 7 years ago and he gave me a medication. I don't remember what it is, but it helped for a little while and I just never went back and saw him. May sort of lead us down a path that, this is a guy that had an obstruction he's just not been treating versus a guy that says, oh yeah, I saw a urologist a few years ago and he did some procedure where he had to cut open something down there and I had to wear a catheter for a couple days and then stricture becomes more of an issue. So we get to be diagnosticians and then the fun stuff of treating the surgical problem comes a little later, but that's one of the great things about the field as well.
And we can't forget about our excellent primary care colleagues. They often will treat these patients, and that gives us a clue, especially if a patient says, well, the alpha blocker and the 5-alpha reductase inhibitor helped, but not enough. Well, that generally helps obstruction, so that leads us toward then. Same thing with bladder relaxants. If they say it helped, but not enough, makes us think there's an OAB component. So we have to put it all into the equation.
And so I like both of you bringing kind of the art of medicine back into it versus us just looking at urodynamics tracings and wondering what the hell we just saw. In regards to, again, I think, Ben, you mentioned this in terms of listening to the patient. Well, both of you did, Craig and Ben. When do you utilize something like a voiding diary in regards to this instance? When do you feel that that's helpful? Because I don't think there's a kind of a code that you can code for in terms of interpretation of a voiding diary, and that takes some time.
Voiding diaries are great. The problem with voiding diaries is they're a pain in the butt to do. I think I'm assessing the patient to say, hey, is the data I get from the voiding diary going to help me? Like any test we order, whether it's a urodynamic, a uroflow, or a voiding diary, if it's not going to really drive or change things, I'm maybe a little less inclined. The case you gave us with Nocturia, is this really Nocturia? He's going to the bathroom 4 times a night and that's it in isolation. Voiding diary, hugely beneficial to rule out something like nocturnal polyuria. Or are we talking about 4 times a night because that's what he remembers, but he's peeing 15 times a day, which is excessive. And this is maybe a little bit more indicative of an overactive bladder or possibly an overactive bladder with an obstruction. So I think that that's a piece of it. When you talk to a patient and you get a sense that they have frequency and it's sort of frequency in isolation and you do your quick assessment, how much are you drinking? What do you drink? A cup of coffee, couple cups of coffee. I don't really know, doc. Sometimes if we're maybe a little less suspicious of a true pathophysiology and more suspicious that this is maybe a polydipsia or excessive fluid drinking, then a diary can be helpful. But you're right, it takes time. There are AI cameras that you can use now to take pictures of a voiding diary. I don't know if any of you guys have tried it.
No.
We have like an actual one that's secure, so it's HIPAA compliant because it only stays in NYU, but you could take a picture and just say, please summarize the diary for me.
Really?
It's like a ChatGPT version and it actually works pretty darn well. So hopefully cuts out some of the time.
Well, I agree. And, nocturia is often the bane of my practice. So when there is a extremely bothersome nocturia or isolated nocturia, then the voiding diary is, I think, the most important thing because nocturnal polyuria was underdiagnosed and so easy to diagnose. And then we can help that with behavior, with vasopressin. So I really go for the voiding diary when someone has a funny story, such as I'm normal in the day and I'm up all the time at night. And I like to quantify it, but sometimes that's all you get. Or my nighttime urinations are a full volume. And sometimes they quantify. Oh, I think it's a can, so 300 milliliters each time I get up to void. And my answer is, well, you should get up. Your bladder's full. But the problem is your bladder's full. So that voiding diary is, again, no risk.
You get any sense that the nighttime urination, let's say without any crazy daytime issues, might sort of favor more of the BPH patient, the obstructive patient versus the overactive bladder patient, Craig? Or you think it's hard to tell?
So it can be hard to tell. I often think, well, BPH should be the same day and night, and OAB should be the same day and night. The reality is it's not. If you get out of bed without socks on and the floor is cold, well, that's an epinephrine surge and that contracts your prostatic muscles and that can give you a weak stream. So you can have BPH that's worse at night, but for the most part, if the symptoms vary day and night, I start to think of processes other than pure obstruction or pure OAB.
So before we delve more into nocturia, which could be entirely itself its own podcast, let's go back to that index patient.
That's why they have you here, Chris. It's like herding cats, right?
Yes.
That's right, guy.
That's why it's St. Valentine's Day. I love you guys. I just want to, bring it back. Let's bring it back. So going back to this patient, obviously I talked about the nocturia, and thank you for addressing it. So let's say this patient is actually treatment naive. Let's say he hasn't seen a urologist in the past. His primary care doctor, because of telehealth nowadays, just said, I'm going to refer it to Craig or Ben and let them handle it, and they'll be fine in handling him. Where are you going with this patient if they're treatment naive and they're in your clinic? Craig, how do you start off? What do you want to do for him?
So, there's quite a bit of data here. He has a low flow, a high residual urine, a PSA that's reflective of a large prostate.
Oh, let me couch that. Sorry. I never did give you the parameters. So let's say this patient, I gave you the parameters. Craig really wanted the uroflow. Let's say his Qmax is 10 mils per second. His PVR is 200. PSA is normal because we did that DRE, normal in tone in terms of the rectum, and then also, or in terms of the anal sphincter, and then in terms of his prostate, it feels like it's normal. And then IPSS is 22.
So we can rely on probability. Severe symptoms on IPSS, elevated residual urine and low flow. Again, one instance, we can't take it to the bank, but statistically, he's more likely than not to have BPH or obstruction than overactive bladder. And, 2/3 of the time we're correct. So I would go down the BPH pathway in him and start with behavior, exercise, and alpha blockers.
Yeah, and I think, Craig, I wholeheartedly agree based on those parameters. I also think about the ease of prescribing something. Alpha blockers, relatively inexpensive, super well tolerated. Couple of side effects we got to talk about, but I'm not filling out prior authorizations. I'm not having long discussions about different classes of medication. And so I'll be very upfront with a guy and say, look, you have a prostate, you have a bladder, we're going to try to sort this out. And I'm pretty upfront if they're having that frequency and that urgency complaint right from the beginning, because the overactive bladder is something I may need to treat. And I bring that concept up right away, and I explain that we're going to try a therapy that I think is going to help. And it's amazing, right? Alpha blockers actually help guys that have BPH. Go figure, right? But you see guys back. And I think the key here is I'm going to give them the expectation, at least in my practice, where it's not just alpha blocker and I'll see you for a DRE and a PSA in a year. I actually want to treat his LUTS, so I got to see him back to say, hey, have you responded the way you think? There are exceptions where it might be really very obviously BPH, and I'm not rushing to see them back, and they're not rushing to see me, but I do realize that sometimes even when you treat the outlet with an alpha blocker, there's more that needs to happen.
I agree. And we also need to tell the patient what is normal. Get up once at 60, twice at 70, 3 times at 80. So I tell them, you're not getting up less than once at night, so we're not going for perfect.
So basically your patient runs away and goes sees Ben on the East Coast.
Good.
I don't know.
Absolutely.
I always have patients who ask me what is normal, and I do give them that spiel about how many times you wake up at night, but then I also say bother, right? Because we also talk about bother in terms of your symptomology and how we treat things. And so, if someone's peeing 4 times a night, but they're not bothered by it, I'm not necessarily running after it, but I don't really give them those values unless they're asking what is a quote unquote normal. So going back to behavioral therapy, Craig, I think we teach Ben, Craig, we all deal with residents and fellows as well. We always tell them behavioral therapy is what we should go first line, because that's what's in the guidelines and everything else. So what are you really telling and what are you expecting in terms of behavioral therapy for those patients who really don't want to take medication?
Yeah, so I think it depends on what their symptom and bother is. I can tell you that behavioral therapy doesn't help that annoying slow stream for the most part, right? I think if it's I'm getting up at night or I'm having some frequency and urgency, then there are things that we talk about in terms of diet modification. I send men to pelvic floor physical therapy. Again, not as effective to treat BPH, but there are guys that come in with a slow flow that might not have the gray hairs on their head. And then you're wondering, is this really an obstructive process, or is this, maybe an obstructive process secondary to a pelvic floor, or maybe symptoms secondary to a pelvic floor issue. So I think a lot about that. Again, the gray hair test sort of puts me toward hey, maybe it's BPH. I think you gave us a 67-year-old patient. Behaviorally, great opportunity to talk about smoking cessation. I think just why not? Great opportunity to talk about obesity and weight loss. Why not? And again, maybe that there's not as much data in the BPH world, but the symptoms that are bothering him are overactive bladder symptoms. And so I want him to realize that, weight reduction can have a benefit in his overall health. And then I think you start to look at things like the diabetic control, you start to look at the medications he's taking. So that's when we get to not only be surgeons, but also medical doctors.
And then as a fan of educating them on what's normal, I tell them we do make more urine at night as we age, and that's why you get up once at 60 and twice at 70. So I say we're behind the 8 ball, and you should drink less after dinner, because it's not common knowledge. In fact, the TV is pushing us to hydrate, that Super Bowl ad that told us to check our pee. So we're advised to hydrate when the behavioral modification is, no, go thirsty. Your brain is smart. Your brain has a thirst center. It'll tell you if you're not drinking enough.
Dr. Comiter, I have been watching the Olympics and I enjoy an espresso at night because I'm part Italian. How are you going to change my behavior with that?
So I don't want to take your joy out of life. But if your main complaint is waking up at night and you have large volume voids, you need to change your espresso to the morning.
Do you ever see this issue with patients who are shift workers and they work the graveyard shift and they have bothersome nocturia, but it's actually nocturia. It's, when they're going to sleep during the day. I mean, Ben, you live in the city. You must have a lot of these patients that come to you with this issue.
So the biggest issue is understanding that, and when you're having a whole conversation and then after about 20 minutes of talking to them, then they sort of allude to the fact that they might be working at night, not during the day, and then you realize, like, I have no idea what's actually going on here. That's when avoiding diaries is useful, and you say, tell me when you go to sleep and when you wake up. But I will say now, Chris, you're doing it too, because now we're fixated a little bit more on the nocturia. So we'll redirect a little bit. But look, these are the problem issues, and I think you're right that this is the stuff that we think a lot about because, again, maybe a little bit of a different view than just sort of focusing right on the prostate. But to be fair, I don't know that I'm going to do a lot of behavioral modification with this guy. And let's say he's only getting up twice a night to pee, but he has that slow flow and the elevated PVR. And I'm explaining to him now, your risk of retention goes up with the elevated post-void residual. Your risk of being in an ER goes up if you don't take the medication. Your symptoms are likely going to worsen. And you can look at old historic, Baltimore longitudinal study data. And, there's a lot of data out there that says the natural history of BPH, there are some downsides to sort of just talking about things and sort of cutting back on fluids. Not to say that we don't offer it, but you're right. I mean, you were playing the obstinate patient before, but there are plenty of patients that don't want to change their diet, and it's still okay to help them even if they're not going to stop smoking and they're not going to lose weight or stop their espressos at night before they watch the luge.
You're exactly right. It is shared decision making, which means we get a vote. So I can't help your weak stream with fluid restriction, with pelvic floor exercises. I can help your weak stream with medications and with surgery. So remember, it is shared decision making, so we need to share our recommendations.
When do you, experts in the field, go from monotherapy to either 2 medications, so 5-ARI and an alpha blocker, or when do you move on to kind of treating the bladder?
I think Craig had mentioned the bother, and there's a lot of bother. Maybe it was you, Chris, that had mentioned it. How are they doing, right? So I see this guy back after 6 weeks. Maybe his residual is down a little bit. Maybe he's down to a 75 cc residual. His flow rate went from a 10 to a 16 or something like that. That'd be a nice improvement, maybe a little too optimistic. But so he's had an improvement, and he's still sort of, mentions that he does, and I'll now do it, but he does still get up twice a night to pee. And maybe during the daytime, he's still peeing a little bit much. Or, again, what really I think drives a lot of my overactive bladder treatment or bladder medication addition is the urgency component. And I think the frequency, could be, maybe it's related to diet, maybe frequency is related to his job or a shift, or he's a teacher, whatever else is going on. But the guy that has the urge where it's all of a sudden and he's peeing in a bottle behind a tree because he has to pee so badly and he can't make it home, or a guy guy that's having wetting, or the guy that has, again, that persistent nocturia complaint along with the daytime symptoms. So for me, obviously, I do a lot of ultrasounds, just a transabdominal ultrasound to size the prostate. But if he comes back after the alpha blocker and let's say he's not flying or he's doing better but not quite there, a little bit of imaging may be better than my rectal exam. I get a sense of the prostate size. The larger prostates, I may go down the 5-ARI route, but there are side effects. There's a long discussion to have about, sexual side effects from 5-ARIs. And I think in some ways, I look at that as a more long-term medication that I can use versus the overactive bladder medications I can add on and sort of see what's contributing here, right? The premise is it the prostate? Is it the bladder? Is it a combination of both? So I try the alpha blockers, see how they respond. Then I'll probably, if it's not that obvious that it's all obstructive and they do have more of that urgency, try the bladder medication, see how they respond. And if they don't respond to, let's say, the bladder med, maybe I back off of that and then use something like a 5-ARI if they have a bigger prostate.
I tend to be a little more aggressive with 5-ARIs up front. I like to think alpha blockers for symptoms, 5-ARIs for natural history. And if your prostate is 30 to 40, PSA is 1.4 or higher, trust shows a large prostate, then I'll add on a 5-ARI on visit 1 to prevent retention, to reduce the risk of surgery. Absolutely not critical of waiting for the second visit, but I like to do it up front. I get much more cerebral when it comes to the bladder relaxant because that's treating a whole different ballgame and has the theoretical risk of urinary retention. But also, if they're now on 3 meds, even 4 meds, sometimes I think it might be time for surgery.
So again, this is the reason why I like to have experts in the field, and I think this is really fun in regards to spending my Valentine's Day with you guys. So Dr. Comiter, I'm coming back into clinic, and I read about this whole, and you're in California, so you must get this a lot, Post-Finasteride Syndrome. Never mind the fact that he's been using finasteride for hair loss for the past 5 years. How often do you see this in your clinic after being aggressive with initial therapy with dual therapy for that? Even though, yes, I agree with you 100%, all the data shows you have less urinary retention, less progression to surgical therapy, right? Hopefully keeping him out of the ER with a catheter.
I'll be honest, I've never seen it. Now, that could also be a bias that I think it's a rare thing. By definition, it's when you stop the finasteride. So I tell the men to keep taking it. There's so many causes for these alleged post-finasteride syndrome symptoms that I tend to look elsewhere. The other thing is if someone took finasteride, had adverse side effects, and they persist, and it truly is post-finasteride syndrome, I don't know how to remedy that. So I tend not to focus on that small risk. And I look at the vast majority of patients who have a positive response to it or have limited side effects or don't have long-lasting side effects when they stop it.
So Dr. Comiter doesn't see it in California. What about Dr. Brucker in New York?
Yeah, I mean, you hear some complaints. I'd say much more commonly, I get the older gentleman that has the breast tenderness, or you get an older guy that says, hey, my libido is sort of shot. Sometimes it's not so obvious, but it comes year 2, year 3 of treating his BPH, right? Guy started on an alpha blocker, you start him on a 5-ARI, maybe he has an MI, maybe he's now on a beta blocker, it's 2 years later, and then you're trying to peel away what you can, and I'll often stop the 5-ARI. I think also early on in the discussion, and it sort of, I think we should mention it, I will mention that there are surgical procedures or things that we can do. I give them sort of that same pathway. I think growing up sort of as an overactive bladder person, we always talk about, explaining to them up front that there are medications and then there are things beyond medication that we can use. I sort of take the same tack now with my BPH patients where I'm not telling a guy he needs a surgery day 1, but I'm explaining, look, you have a condition. We talk about the natural history of the condition, BPH, not necessarily bringing up overactive bladder unless he has that urgency complaint. If he has the urgency complaint, we talk about both. If it's not so much urgency, we're talking about the BPH piece of this and that there are interventions if the medications are not working, just so that, he does come back and we do continue to the discussion. So because I have that discussion up front and because I think men do quite well with a lot of the minimally invasive surgeries and sort of endoscopic surgeries we have, a lot of my 5-ARI use ends up being, again, in the obvious guy that's maybe not the right guy for surgery based on his maybe desire to avoid surgery, or even the guys that may have had had a surgery, and then we're looking to sort of slow that regrowth down the road. And I think the one thing I'd also mention is, we all have a different patient in our mind when we're mentioning some of these things. So if you're listening out there and saying like, gosh, why aren't they just putting them on alpha blocker, seeing them back next year? I'm thinking the last guy I saw that ended up having, let's say, a major complaint of an overactive bladder. So it is funny how it sort of gives us a little bias depending on what the patient is we have in our head.
And it's a dance. When is the right time to introduce the concept of surgery? I agree with Ben. Sometimes first visit, sometimes not until the fifth visit. But what I like to tell them when that conversation comes up, I say 95% of the time, we do surgery because you ask for it. Your symptoms are too bothersome and the pills are not good enough. Only 5% of the time do I pull out my finger and say, you need surgery. You're ruining your kidneys. You have a catheter. You have a stone. You have infections. So it is a patient choice. In that shared decision-making model, 99% of that sharing is with the patient. So we bring it up when it's appropriate, and I just let them know this is the definition of elective in 95% of the people.
Yeah, it's interesting. I think we also, as urodynamicists, have a little bit of a bias to see those patients that are bilateral hydro and super distended bladder, right? Because they often get sent to us for a urodynamic, or they're not that straightforward patient. So a lot of my BPH practices it revolves around that, because these are not hey, I have some LUTS and we're going to just treat the LUTS. Again, maybe it's an academic center, maybe it's a tertiary referral center, maybe it's being a urodynamicist or a glutton for punishment. But we do see a lot of those bilateral hydro and they can't void, or they're on CIC, and then we're pointing a finger saying we'll do it, or we're pointing a finger at that urodynamic tracing and saying, hey, it's flat. I don't know if we should do it. But that's I think probably a whole nother discussion. But I think in probably all of our practices, we see a little bit of a higher incidence of that.
Yes.
So let's get into kind of surgical therapy, because we've decided that it's not good for this man to continue to go along as he is and start to get the remodeling that you're going to get from the bladder because of an obstructive outlet. So right now we're busting the prostate in regards to what's going on. But Craig, what's your thought process now in terms of he's failed medical therapy? You're going to surgical options for him. Does his history make anything different in terms of how you're going to counsel him on his options?
So no, because he has options for surgery. I would do urodynamics if I had apprehension about the diagnosis, but this sounds like a BPH, BPO kind of guy. And if pills are not working to satisfaction, there's all the surgical options depending on prostate size. And I think if your prostate is less than 80 cc's and there's no median lobe, then we can offer you just about anything surgically. And I give him the risks and the benefits of each, focusing on sexual side effects. And if you have a large prostate and or median lobe, I push a lot more toward resection rather than a mist. And then I give them the risks, the benefits, and the alternatives of each resective surgery.
Ben, would you kind of say the same in regards to what Craig is thinking?
Yeah, I do. I mean, a little bit maybe apropos to the discussion and the question posed, this overactive bladder piece of it, I do probably have a little bit of a bias toward maybe avoiding a mist in general, if they're asking me my opinion, if there really is a big component of overactive bladder. And the thought process is, I don't want to do a procedure that might not actually relieve the obstruction or the blockage, and then sort of not know whether I've relieved it. And I think the patient I have in mind is the guy that really, has the obstructive symptoms, has, let's say, the urgency incontinence, the slow urinary stream, more the BPH. And so, yes, I think you offer all of them, you discuss all of it. I think that the point that I'm making is I want to do something that's going to definitely relieve the obstruction. Now, on the other hand, if a guy has a lot of storage symptoms, urgency, frequency, and is afraid of urgency incontinence, then there may be an advantage to a mist therapy to avoid, worsening his urgency incontinence. And I think the other piece or the other patient type that we probably all see a lot of are these patients where it's the patient that might have an issue after a surgery. If it's just straightforward and it's a slow urinary stream, I don't know. I see them, but I don't see them all the time. It's usually the guy that's having the urge and he's having incontinence, and the primary urologist told him he shouldn't have a TURP because he's going to be incontinent. And then it's sort of guiding him through the process to say, look, we're going to relieve the obstruction and then ultimately treat the bladder if needed. But yeah, I think Craig's general take on BPH, 1000% agree. Some of the little nuances do make me sort of maybe push guys in a little bit of a different direction.
Yes. Well, we're all looking for that dream patient that says, whatever you say, doc. That is the dream.
Correct. 1000%. And again, these are suggestions that we make. And I think it is important to give a little bit of that, hey, this is what I'm thinking. This is why I'm thinking it. But every patient's going to be very unique. And look, I think we should offer all of these things. And again, even when it comes to sexual function, how important is that? Where are they in their life? Where are they in their sexual life? What's their erectile function like? Ejaculatory function? What are the side effects of medications? So there's a whole slew of things. These are not always the quickest and easiest discussions if you're going to be really thorough and truly inform them of all their options.
Kind of going back to minimally invasive surgical therapy, Ben, I'm not sure if you're referring to this, but are you kind of referring to legacy technologies that in the past have been looked at in randomized control studies and the urodynamic patterns don't really change after you get them, like TUMT?
Yeah, I think that we've had a long history of procedures that are great because they're minimally invasive, right? But if we're looking, and again, wearing my urodynamic hat now, I've seen that they have an obstruction. I want to relieve that obstruction, right? They have an obstruction. I want to relieve the obstruction. So look, you can argue symptom improvement is the most important thing. And I don't disagree that that is the most important thing. I'm trying to figure out with their urgency or frequency or their overactive bladder symptoms, are they going to get better or not by relieving the obstruction? And my general sense is some of the more minimally invasive legacy procedures, it may be hard after a procedure and they still have urgency to know if the obstruction's relieved or not. And then you do another urodynamic and they're still obstructed and you're sort of back to square one. But it may have been that you had that discussion and the patient chose that because of the ejaculation preservation or the office-based procedure, less downtime. And I think time will tell with some of the, we'll call them newer minimally invasive procedures. Again, there's a huge segment that'll definitely benefit from this, maybe just a little bit of a different patient type than what we're talking about here, with a lot more of that frequency, urgency, complex.
Craig, I'm going to come back to you in regards to what you talked about with your pathway and algorithm for treating someone. You mentioned that middle lobe or intravesical prostate and MIS, since we're talking about it. It seems that the data would suggest, some of the data, whether you believe it or not, would say that's okay to go ahead and treat those patients with a minimally invasive surgical therapy, even if they do have a middle lobe. What's your thoughts on that?
I don't like to offer my patients things that are okay. I like to offer them things that work well. So the median lobe, in some ways, is the easiest thing to treat. It doesn't respond well to alpha blockers. That's, in the obstructed patient, a surgical patient. And in my experience, getting rid of that median lobe with electrocautery or laser or water jets almost invariably fixes the obstruction and most of the irritative symptoms. Those remaining irritative symptoms can be treated with medications. I'm not impressed with a 95% improvement in LUTS using a mist for the median lobe. So you are correct. It may work. And that's how I phrase it to the patient. If he says, well, can I have one of those? And I don't want to use brand names. Can I have a mist? I'll say, you could, but why don't we do a surgery and relieve your symptoms?
Yeah. And again, the mist and sort of the place for the mist may be the guy that's not doing well on medication and really doesn't want to do one of these other procedures that Craig or I would offer. And then it's like, well, you either suffer and take medication or try mist. So it's not, I don't think either of us feel like there's not a place for it. There's certainly a place. But again, if we're looking from a urodynamic lens, an obstructive lens, an overactive bladder lens, I think it's a maybe not as straightforward of a patient.
There's also this thought, Ben and Craig, that maybe ablative therapies, and aquablation is an ablative therapy, but more specifically, photovaporization of the prostate, also an ablative therapy, more irritative LUTS in the recovery period afterwards, or maybe more irritative LUTS. So for a patient with irritative LUTS to begin with, is that something you kind of steer them away from or something you're still apt to pursue?
Yeah, so when you say irritative LUTS, I would sort of clarify with the patient a little bit. After green light, you can have dysuria, burning with urination. There is no doubt that you have that. I describe it, as one patient described to me, as pissing razor blades, just so they have that thought in their mind. It's usually not that bad. And this is, again, for a PVP, They understand that there are medicines we use that can ultimately treat it. And beyond that, I would say, I don't know that I get a lot of other irritative symptoms, right? Like the frequency, the urgency. I think the bigger place where you get that is when you don't actually relieve the obstruction, or if a guy has a lot of sort of that persistent frequency, urgency, I wonder, hey, did I relieve the obstruction? It's not to say it can't happen, it can happen. And I think, somewhat similarly with aquablation, I don't necessarily see a lot of irritative symptoms. I think there is a little bit of the sloughing. There's sometimes a little bit more bleeding immediately post-operatively, but I don't shy away from them. Maybe things that leave something in the prostate or that, will ultimately take a longer time to heal in the prostate, I'd worry about. But in terms of the irritative symptoms, sure, TURP is probably the best. I don't think guys really complain about it, but again, just not something that I shy away from based on, let's say, the frequency or the fear of burning. If a guy has a lot of pain issues or he's telling me, he's one of these high-tone pelvic floor guys, then I might tailor a little bit differently. But irritative symptoms for me or frequency, urgency, a little bit of burning, I wouldn't shy away from either of those therapies we talked about.
I agree completely. So I say, are you a missed patient or a resection patient? Once you're a resection patient, if your prostate is less than 100 cc's, I say they all work the same. HoLEP, photovaporization, water jets, or TURP, but they differ by side effects. One side effect of the photovaporization is it takes longer. So I think a TURP or an aquablation is simply faster. And that's better for your 67-year-old brain to have a quicker anesthesia. So I favor the faster surgeries. However, if you're on a blood thinner or have a bleeding disorder, we're going laser. If the patient says, I want to maintain ejaculatory function, well, that's a water jet therapy. And if the patient says, look, I just want the easiest recovery, shortest catheterization, well, that's a TURP. So again, I decide if you need a resection, and then based on, is it super large? We're going water jets or HoLEP. Are you a bleeder? We're going photovaporization or HoLEP. Do you need the shortest catheterization, quickest recovery? You're getting a TURP. So we do fine tune, but in general, outside of the supersized prostate, all of the resections work well because they turn this into that. So they're pretty darn similar. And Ben's right. Yeah, there can be some irritative symptoms for a week after the surgery. Surgery hurts.
Yeah. And, I'd add, I guess, some data on ejaculation sparing green light, just to sort of put it out there. And certainly some data that comes out now that says even aquablations, maybe the ejaculation dysfunction might be higher. So I think you go back and forth. You have to have the discussion. For me, in that shared decision-making, what are the patient's values? I mentioned that for me, I'm keeping my TURPs overnight in the hospital just because that's sort of how I train, and they're on CBI, and that sort of might scare some people off. Other people are not bothered. My green lights, they all go home. My green lights have a catheter, let's say, shorter than my aquablations just because of a little less bleeding. So, you're trying to get a sense of what is bothering the patient, what sort of their values are. And then there are those little things like Craig mentioned, the anticoagulation, the need for anticoagulation, or, sort of all of these different aspects, right? Are these guys that I might want to have, a catheter in a little longer, a little shorter? So I think most of us offer lots of different options so that we can actually tailor the therapy to the patient. But I think the difference between, let's say, the enucleations, the vaporizations, the resections, the ablations, they're not that different in terms of like the ultimate relieving of obstruction or Craig sort of opening up of the channel. I think they're all the same. And then the fine-tuning stuff comes after, which is what the recovery looks like, what the hospitalization looks like, et cetera.
Craig, how are you counseling this man on how his, again, I don't want to go down this rabbit hole, just really quickly, his nocturia, how's that going to improve? Because he honestly is really tired during the day, and he thinks it's low T or it's due to his nocturia. So
okay, so getting into the low T, I'm not so...
No, don't go to low T. Don't do that.
No, he just wants to go back to the nocturia.
No.
Okay.
We'll let SMS handle that. No.
Okay.
SM&A. No.
So his most bothersome symptom is nocturia. So up front, I would be aggressive on treating him. Don't drink anything after 5 p.m. unless you must. I would go that way, the leg swelling. So we're not doing the Nocturia podcast.
No, we're going back to the surgical therapy. He's like, after you do my aquablation, how are you counseling him on that?
So We cannot predict the future, sir. However, you're 67 years old, and I think you're at least going to get up once and maybe twice, and that might be the best possible outcome. And if that's not sufficient for you, then surgery may not be a good option. But if we unblock you, and your nocturia still persists, then I'm really excited to give you bladder relaxants at bedtime. Whereas I'm not so excited now with your residual urine of 220. So I leave the door open that it may not fix your nocturia because I'm not trained to fix a sleep disorder or habit. And when you're 67, you have a sleep cycle that I may not affect. But I can fix your bladder postoperatively with bladder pills.
I don't disagree. I think the two things I'd add, when you get the guy that has that question, what I will, again, I like urodynamics if there's a question of nocturia and is the nocturia driven by obstruction? And I can look at a urodynamic and then definitively say, you are obstructed, sir. And in cases of obstruction, if I relieve the obstruction, there should be an improvement in your nocturia, right? If it's one nocturic event improved, that may be enough for him. So again, 4, I could get you to 3. Is that good enough? But it's easier for me to get behind the recommendation to say you're obstructed and now you are not obstructed after. So sometimes when I'm posed that question, the urodynamic does help inform because there are times when you're not sure what's driving the nocturia. And then the only other point I wanted to make, and I think Craig mentioned it, and it's not wrong, but just to sort of expand on, is at night and sort of the bladder relaxant he'd use, and he's concerned about the incomplete emptying. I think one of the advantages of beta-3 agonists, and maybe it's a little bit of me being too aggressive with them, but I don't really see, and I don't really have any fear or concern of affecting bladder emptying with a beta-3. And I know there are package inserts and it says, hey, be careful that it can cause retention in men with BPH. But if you look at the fine print in some of the beta-3 agonists, it says, and men that are concurrently treated with antimuscarinics. So again, in an ideal world, I might be using beta-3s and then I don't have that discussion. But Craig's right. There's still the number one prescribed overactive bladder medication is an anticholinergic that's, got the potential to affect bladder emptying. So I also agree, though, that any of our overactive bladder therapies work better when there is no longer obstruction there. So that's sort of, I think, real important to emphasize to guys as to why we do it in a stepwise approach and why we treat the outlet first and then the bladder usually second, if they're either equal or sort of at least there's a component of an obstruction that's present.
So Ben, I'm gonna bring it back to this in saying that the reason why all our female patients do so well just on antimuscarinics or beta-3s is because they don't have a prostate, right?
Exactly.
I want to run through some quick hits, Craig. So let's try this. When or do you ever do Botox at the same time as as an outlet procedure? There's a big sigh there.
Well, because I can't say never. I often do Botox in the setting of an artificial sphincter. That's an outlet procedure for someone who's got stress incontinence because
it's an increasing outlet procedure.
There is
right.
zero risk of causing retention in that person. But I don't mix it with outlet resection or a mist because if they're in retention post-op, is that a surgical complication, a stricture, incomplete resection, or is it the Botox? And I don't like to confuse things. So I would say I almost never would do a Botox at the time of an outlet procedure because Botox can be done in the office and it is so well tolerated. I don't see any big advantage of doing it while they're asleep.
Yeah, I've had some experience doing it. So for me, it's the guy that has been on overactive bladder therapy. He's been on BPH therapy. He has a urodynamic that shows like nasty overactivity. And I'm really concerned that he's already having some urgency incontinence and he's going to have really hard urgency incontinence afterward. And I'm not going to love, he's not good enough with just the beta-3 or maybe the beta-3 antimuscarinic combo, and he's not going to do well me having to scope him 2 weeks after his outlet reduction procedure, and he's not going to be happy with me waiting, 6 weeks or even 3 months. So there are guys that I've done it and I say, look, I can do it. The beauty is Botox is not going to really start to work for about 2 weeks, right? So in some ways you'd say, well, is it really helping? But most guys can deal with a little bit of the burning and the urgency for the first week or two, but it's the real florid incontinence, the urgency incontinence that I'm trying to prevent. I haven't had any patients where I've done it where I've regretted doing it. So I think that it actually is something that I do. I don't know that it's always necessary because so many guys get better with their urgency and frequency when you treat the outlet. So for me, sometimes the urodynamic helps drive me, and then their past history and response to the overactive bladder therapies would also factor in.
So because, Craig, you're mentioning our history as a society of urodynamicists, I mean, we've been talking about urodynamics a lot, and I know you want to drive business and you want people to come to clinic and get referrals. When is it appropriate to get this guy to urodynamics before doing any of the above?
It's appropriate when it changes your treatment. If there's a question, are you obstructed or not? And if you're obstructed, we're doing surgery. And if you're not, we're not. Then I think urodynamics is very strongly indicated. But if you're confident in the diagnosis, large prostate, high residual urine, low flow, then urodynamics is unlikely to change my recommendation for surgery, so I wouldn't do it. So I do urodynamics often. I never regret doing urodynamics. But if I'm 95% certain of the diagnosis and plan, then I don't do urodynamics.
I agree. I mean, if there's a question to answer, and that question may also be a patient's question, not mine, I can be pretty convinced that this is what it's going to be. I mean, we get good at pattern recognition in what we do, and I'm pretty certain, I'm not perfect, but I'm pretty good at saying, hey, this is what the outcome is. But the patient sometimes is not understanding it or can't sort of use it. So in some ways, like, yeah, we use it to define obstruction. I don't need overactivity to sort of say that they have overactive bladder. You know, some data about phasic overactivity versus terminal overactivity and what's going to resolve after from outlet reduction. But it's counseling, and it's often useful in the complicated patient where there is significant storage because of the questions that arise, which is, you know, after the procedure, if they're still having symptoms, you know, did you relieve the obstruction? Well, sometimes if the obstruction maybe wasn't there to begin with, then doing yet another outlet reduction procedure is not going to help. And if you know that there was obstruction and you repeat a urodynamic and now there's not obstruction, now you say, all right, it's an overactive bladder. So I agree, though, it's not needed for everyone. So, you know, you've been following a guy for years. He sort of had the natural history and progression. He's not overactive bladder predominant, no problem. The fun cases are the ones where it's sort of a little bit muddier and a little bit of a mix. And then you're using the diagnostic tools, their response to medications and sort of to help. But helping counseling, I think, is another potential role. Not that that's the only role, but I always have a question that I want to answer if I'm going to get the study.
And then there's minutia, like Ben started to mention. If there's detrusor overactivity early on, that's not likely to resolve with TERP alone. And that's someone you may want to do the Botox at the same time, as opposed to at 450 mils, there was terminal detrusor overactivity that is likely to resolve with surgery. So urodynamics can, even in the patient where we know they're obstructed, can influence our OAB treatment with intraoperative botulinum toxin or aggressive bladder relaxants, or avoiding surgery altogether.
You need to just turn down the fill rate.
Right. So I'd also say, you know, remember that the patients are never that simple either, right? This is a guy that has Parkinson's or might have Parkinson's. This is a guy that has a slip disc. This is a guy that had a history of a spinal injury years ago, right? And again, you start to see more and more of those in your practice. The urodynamics has, again, it's not changing the idea of doing a TERP, but if I can tell you that you're 80% likely to respond well to this versus I don't know if it's going to work or not, I think as a patient, sometimes you need to have that data, right? We don't have really a true risk calculator to say, are they going to respond or not, with the absence of at least some urodynamics. And it helps us look at and think about and helps the patient understand that there's a bladder and an outlet and the two sort of in the combination, you know, interplay.
I agree.
Craig, I'm going to give you, and Ben also the same, 2 minutes just to rant about whether you're busting the prostate or blaming the bladder in regards to what your thoughts are in terms of our discussion that we've had today. Craig, you're up. And I'll mute you if you
okay.
go over 2.
So I don't know if I bust prostates and blame bladders. I do often blame prostates and bust bladders. So bottom line, on visit 1, I have to start thinking, is this your bladder? Is this your outlet? Or is it both? And I keep it very simple. If it's your bladder, we're treating it. If it's your outlet, we're treating it. And if it's both, we're treating both. So I don't need 2 minutes. I'm done.
He sees his time.
I sees his time to the the discussant from New York. Yeah, look, I think it is something that it's going to depend. You have a 40-year-old guy that comes in, there should be a little red siren spinning your head saying, I don't know that this is really BPH and so straightforward, right? The answer may be trial an alpha blocker. The answer may be trial the OAB med. But, in general, there are men that have just overactive bladder. There are men that need to be treated overactive bladder. But the numbers and the data for a 67-year-old guy, with a slow flow rate and an elevated PVR would say this is a prostate process. So I think if I'm going to try something empirically, just given the ease of it, given the likelihood of it, given, the probability that they'll get better, we often treat the prostate or the outlet, whether it's the prostate or the bladder neck. But I think if someone's not responding, I'm always thinking to myself, do I need to rethink this? And I think the piece that we unfortunately often fail at as urologists is we treat the outlet and then we sometimes just forget about the bladder and we accept the fact that hey, they're still peeing frequently during the daytime, they're still getting up at night, but their flow rate looks fine and their PVR is low. And that's where you put on your ERPS hat or your overactive bladder hat and you say, maybe we should be thinking about getting more aggressive with their overactive bladder therapy. And with that, I'll take part of my time to thank you, Chris, and thank you, Craig. I learn a ton, working with you guys and having these discussions. And it's fun to see that some of the things I'm doing, maybe you guys are doing as well, and I'm not doing it wrong. And at the same time, maybe some of the stuff, hey, I should think about it a little bit differently. And so it's always fun to have these discussions. And I want to thank you guys and SUFU for the opportunity.
Well, thank you. And I echo those sentiments that I learned so much from these interactions. And it sounds like we're often saying the same thing. I can say I treat the outlet or the bladder or both. But the reality is the patient, the referring doc, often is focusing on the prostate. We were raised until the mid-1980s that if you're a man, it's your prostate. And it's only the last 35 years that we're actually learning men have bladders too. So although we may realize there are bladders and outlets, there's a big component of the community out there that is focusing solely on the prostate because that's how they were trained.
And we do. I know now I'm over my 2 minutes, Chris. You're going to pull the hook out.
Mute.
But the other, and maybe it's another podcast about this. But what happens when you don't treat the outlet obstruction and you wait? Then does treating the bladder become more difficult? And I would say yes, absolutely. Which is why I think as someone that has to treat the overactive bladder all the time, I would almost rather treat the outlet a little bit more aggressively, a little bit more upfront, because I think it's an easier overactive bladder patient to treat rather than obstructive patient for years and years, where their bladders end up more of a end organ or end disease sort of state.
And I would agree with you.
Yeah, so Dr. Brucker and Dr. Comiter, I think we came to consensus about in terms of treating what we should treat first, and also the fact that if you don't treat the prostate, then you do have the bladder become an end organ state where the pathophysiology change may be much harder to treat. So I think what I've gained from this is an awesome appreciation of my colleagues who I work with and how well-spoken they are and what they know and the knowledge that they bring. And the fact that we can come together like this to talk about different difficult cases and enjoy our company together. So thank you so much.
An expert's only someone that's made all the mistakes before. I think that's a Niels
fair enough.
Bohr
I like
quote,
that.
Right?
That is
So,
right.
We're no expert. We've just made lots of mistakes along the way.
So again, Dr. Comiter, Dr. Brucker, thank you for your time and thank you for SUFU for sponsoring this. Thank you for your involvement with should we blame the bladder or bust the prostate?
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.